Well, that last session left everybody really excited and really energetic and with thousands of questions. So Karthik, you're going to have big shoes to fill. Karthik's our moderator for this next session. We're talking about hindfoot trauma and arthritis. Our sponsor for the session is Miris, and it's all yours, Karthik.
Thank you very much, Selene. Firstly, many thanks to Selene for having invited us to be part of this academic bandwagon. It's an extravaganza, the likes of which I haven't seen before, and I'm very grateful that you've given us a chance. I bring you the warmest of greetings from the British Isles. We've got representation from all over. But firstly, I'd like to raise a toast. As we are Brits, we like our beer, and this is to the very best for the Parekh Family Foundation. I'd like to introduce my glitterati. We've got Senthil Kumar, a well-known orthopedic foot and ankle surgeon from Scotland, the Glasgow Royal Infirmary. We've got Hiro Tanaka, who's a well-known name here in the United Kingdom. He holds many positions, not least the treasurer of the British Orthopedic Foot and Ankle Society, a very important post. He holds the purse strings. And then we've got the Sheffield Shamans, because they wield some remarkable scientific magic. We've got Mr. Chris Blundell, the former president of the British Orthopedic Foot and Ankle Society, and of course, Mark Davis, who is the secretary of the British Orthopedic Foot and Ankle Society. Now, we all know that, towards the fag end of a conference, we are sort of slowly walking our way to the bar. And it is here, when we have a chat with a variety of our friends, peers, mentors, that we learn an awful lot. So we're going to bring this down to a pretty chilled out conversation, really, between us. We're going to talk about hindfoot arthritis, diabetic hindfoot pathology, and some hindfoot trauma thrown in, all of which make for an interesting kaleidoscope of cases. These are going to be case-based, as we have stuck to the mandate, unlike some of our colleagues whom I've heard through the day before. That's great, guys, and that's what we do best. We stick to the mandate. So I'm going to ask Senthil Kumar first to kick off with his case, please. Could you kindly share your screen, please, Senthil?
Yeah. Thank you very much. Hope we can see the first slide. Thank you very much for that introduction, Karthik. It was very kind. As you said, we've all got patients that we found difficult to manage, quite daunting to start with, but equally enjoyed managing them, treating them with good result most of the time, but unfortunately not all the time. But also we learned quite a deal from these patients, and I would like to present one such case. But there's one where sometimes you don't know where to start, and so this I will present, and then we will have a discussion a bit later on. The patient that is a 59-year-old. She came to see me 3 years ago, having had multiple surgeries in the north of Scotland. She had rheumatoid arthritis, and she has had knee replacements and revision knee replacement and so on. So she was treated by a surgeon who did a lot of arthroplasty surgery. But some of those surgeons also did a lot of other joints and elbows, shoulders, and foot and ankle as well. So he had, again, done a series of procedures. He started with the hallux valgus correction. He went on to do triple fusion. It's not something that you would recognize as a triple fusion, but there's a triple fusion surgery. Subsequently, there's a calcaneal osteotomy because it didn't really correct the deformity. And eventually, he also did an ankle replacement because how difficult could that be? Because he can do revision knee replacements, and ankle is, just an extension of the same concept, perhaps in his view. So she has had all this surgery, but unfortunately, none of them actually gave her any significant relief of symptoms, and she had problems. Essentially, her problems were forefoot and also on the lateral side of the ankle. The hallux valgus had returned, and there was an ulcer between the second toe and the hallux because of the deformity. And the lateral ankle pain was the main thing in the hindfoot because the heel was in valgus, because that original deformity was never really corrected, and then the impingement was quite bad. And the replaced ankle didn't really have that much movement, reduced movement, but equally painful movements as well. And I will show you some x-rays of that. This is the forefoot. I don't have, unfortunately, all the x-rays for you to see. Essentially, it looks like he had done a Keller's type arthroplasty, excising the proximal half of the proximal phalanx, and that was the correction that he performed, which left her with the hallux quite short and defunctioned, essentially. And you could see the triple arthrodesis. Again, you wouldn't recognize that. I think there was no preparation, no attempt to denude the articular surfaces of the cartilage, and a staple across the pteronavicular joint, as you can see. And this was an X-ray after the calcaneal osteotomy was performed, and the screws there and subtalar joint clearly hadn't fused. There is the ankle replacement. Wasn't really, I think there's a lot of valgus, painful, and it's failing loose tibial component, as you can see. So that's where she came to see me. So all of the areas are painful, symptomatic, and she would like something done. So those are the x-rays, and perhaps I could come to you, Karthik, for the discussion, and then we can then take it from there.
Certainly, but I think it's well worthwhile opening it to the panel. I think we need to concentrate on what the algorithms ought to be, what you should correct, what you shouldn't correct. So can I sort of pass this on to Mr. Davis? Would you like to ask Senthil something for us?
Senthil, the ankle replacement, is the ankle replacement painful?
It is painful, yeah. It is malaligned, as you can see on the x-rays, and it's still in valgus, and it was painful.
Okay, and has there been any suggestion of infection at all after the ankle replacement?
Fortunately, no. There was some delay in healing the original wound, so he had a kind of, you can see the kind of very unsightly scar, badly healed scar, but nevertheless it's healed, and I did have bloods and so on, but they were all normal. No evidence of any infection.
Okay, so I mean, effectively what we're dealing with is a painful ankle replacement. We have issues with potential non-union and unprepared joints through the Chopart area, and we have deformity associated with that, and also with the forefoot. So there's an awful lot going on in this foot, and I would obviously be thinking in principle to deal with things from proximal to distal in terms of trying to rectify any issues. Is there any information in terms of a CT available with regards to union of the triple complex and whether or not there are any cysts around the ankle replacement?
No. I didn't do a CT scan, but we can tell you that the triple, we can actually see on the X-ray the triple joints hadn't fused, and they are still very open. But there was some osteolysis under the talar component, but I don't have a CT scan to show you.
But in terms of that, it looks as if the calcaneal cuboid certainly hasn't fused, but it's difficult from the projections I've got about making a decision about the TNJ and the subtalar joint.
I think
if I can move you on, Mark, you've drawn the information out of Senthil, like blood out of a stone. Can we move to Chris? Chris wants to say something.
Only because it's interesting that, Mark, you said, start proximal to distal, and that is, what we do when you've got deformity at the hip and then the knee and the ankle. But I'm not sure I necessarily agree here in that it would be interesting to know, before the ankle replacement was put in, was the triple complex realigned effectively? So it's almost impossible now to determine where the level of deformity is. And I wonder whether the triple complex might have been moderately well aligned, at least at the subtalar and heel axis. And the ankle's drifted into valgus because the ankle's put in that way. So I would want to go back and try to get some old films before the ankle was put in.
I think, I mean, given that the triple joints are still open, I don't think there was any attempt at correcting it. I think it's one of those techniques where I have seen people just simply put some metal work around the arthrodese joints, expecting them to fuse. But there's no attempt at correcting this deformity. So the joints are still open, and the deformity remains uncorrected.
So, Hero, can I move to you now and ask you what you think your algorithm would be if you were presented with this patient and you've got the information that you've got now? There's no infection, there's residual hindfoot valgus, there's a horribly shortened first ray with pain in all of these areas.
Yeah, I think the first, this is the typical kind of patient who has significant symptoms, but radiographically, you cannot make an algorithmic decision based on radiographs. I mean, the pain could be coming from anywhere, whether midfoot, it could be coming from the ankle replacement, it could be coming from malalignment, it could be coming from the forefoot. I mean, look at the second metatarsal, it's hypertrophied like crazy. And this is where I think we need to move away from the technical elements and then just sort of, otherwise we're going to be focusing on the ankle replacement because that's the most exciting thing. And actually, with patients like this, I really sort of sit down with them and I actually try and formulate a list of what their symptoms are and where they believe that it's coming from, and then put pros and cons of each of those elements so that you can get a kind of a more holistic approach. Because otherwise, if we focus and narrow down on certain joints and certain problems, I think at the end of the day, even if we address, let's say, the ankle replacement, I'm not sure whether the patient's going to have a happy result at the end of the day. So I think this is one of these situations where we do need to take a step back. All I was going to suggest was basically in terms of investigations, I often find that in this situation, a SPECT CT is quite useful because that gives a real map of which areas are hot. And it's kind of a broad investigation that allows you to target down in certain areas.
Okay, well, it's quite clear that none of you are wishing to nail your colors to the mast. So can I go back to Mark and say in 20 seconds, what will be your order of resolution of this particular problem, Mark? Come on, spit it out.
I'd redo the ankle replacement and certainly redo the triple at the same time, probably.
Okay, Chris, very quickly.
Redo the triple, leave the ankle, let that settle, and then revise the ankle.
Hero?
Absolutely not. I would not immediately go to revising the ankle. This needs to step back, proper investigations, proper discussion with the patient. As I said, I would get a SPECT and then be reasonable about the decisions that I make. Yeah, but okay. I wouldn't immediately go to surgery. Surgery is not the thing that's on my mind.
Okay. Well, Senthil, perhaps you can now tell us. You've got a couple of minutes left, so you could tell us what you did.
This is what I did. I think, what she wanted was her forefoot done because, patients, I think they've got other priorities. Her son was getting married. And she said, look, could you do something to the front of the foot so she can wear a shoe on the day? So that was her priority. Obviously, we have to respect that. But my plan was to do the hindfoot first and then go to the forefoot. But because of that, I went ahead and I did the forefoot first. Some of the metal work is obviously causing a problem. There's a distraction orthodesis because you needed the length to the first metatarsal. So I put an intercalated bone graft from iliac crest and plated that and used that extra screw to get the fusion done. And so that kind of restored the weight-bearing function of the forefoot to an extent, but there was some concern about whether we are going to be, going out of position when we correct the hindfoot. But this is always the difficulty when we do the forefoot initially before the hindfoot. So I did that first, and then a year later, so there's a lateral view of the first MTPG arthrodesis. Then the next year I went and did the triple arthrodesis. Again, I was able to correct it only modestly because of the ankle replacement was still in the valgus position. So that when you look at the X-ray, it looks as though it's still in a lot of valgus. But I was able to correct, and you can see there's some space between the lateral malleolus and the calcaneus at this stage, and the fusion was certainly beginning to happen. And then a year later, I did the ankle joint. The option was to fuse it, replace it, but I went for the X-ray of the triple fusion. definitely calcaneal cuboid fused to talonavicular fused. Then I did an ankle replacement, a revision ankle replacement. The original ankle was removed, and the alignment was certainly achieved. With this particular prosthesis star, they have a very big revision polyethylene that I could use, and there was good bone. The whole calcaneus on the talus gave me a good chunk of bone to play with, so that I could put the talus in. But in spite of that, the tibia had to be resected further.
So did that cure her pain?
It did. So that
Okay,
X-ray, what you see is a 1 year post-op X-ray. So the pain was, in fact, relieved, and she was happy with the whole foot, including the foot alignment and everything, and she was pleased with it. Yeah,
Brilliant.
That's a good outcome in the end.
Thank you. It's an interesting concept, starting from the forefoot and moving to the hindfoot, something that I would almost never do, but it clearly has worked for you. So I agree that the preferred option would be the hindfoot first, realign it, and then work around the hindfoot to get your final alignment right. Okay, thank you very much, Senthil. That was an interesting case. We're going to now move on to Hiro Tanaka, who's going to talk about one of his horror cases, a patient with hindfoot shock arthropathy. Hiro, all yours.
Yeah, okay. Can you see the screen?
Yes, yeah.
Okay, great. Yeah, so this is a story of a patient with diabetic hindfoot shock arthropathy, and this patient's kept me up many nights in the previous years. So I picked this case for two reasons. The first reason is basically a technical one about when enough is enough, essentially. And what I tend to find is that I'm always on the side of reconstruction, but actually what price is the patient paying for my kind of enthusiasm to try and reconstruct this patient's hindfoot? And the second reason why I picked this case is that there is a very human element to this, because I find that a lot of the patients that I treat for over 10 years or more, and they come back and forth to the clinic, they develop a relationship with both myself and the clinic staff that's kind of akin to an extended family almost, especially when they live alone and they don't have any sort of close family members. So this is why I picked this particular case. So let me tell you about him. So he is a 63-year-old gentleman when this particular event happened. He's an established diabetic neuropath. He's been coming back and forth to the clinic for over a decade or so with multiple small problems, which were managed. He's got a BMI of 56, which is not abnormal for South Wales, actually. This is relatively...
Watch out, Hiro. Watch out.
From a medical standpoint, I mean, he wasn't particularly great. He's had a previous ischemic heart disease, got lymphedema. And importantly, he lived alone on his own with a dog, which he loved very much, the relevance of which will come later. So he attended the GP practice just for a lymphedema check, and the GP sent him for an X-ray one day. And this is the X-ray. He wasn't particularly symptomatic in the ankle. It was just maybe slightly more swollen than usual. So, you know, nothing terribly abnormal. The joint space is a little bit wide on the ankle there, but it's a very Aquinas X-ray. So he came to the clinic 3 weeks later just for a routine check, and he wasn't symptomatic. And his ankle was hot and swollen, but he had no pain. There were no ulcers. Vascularity was normal. CRP was slightly elevated, and HbA1c is 92, which for him wasn't too bad at all, actually. But the X-ray, definitely there's something weird going on here at the subtalar joint. That's his lateral view there. So certainly with those kind of appearances, there's something going on, some deformity going on at the subtalar joint there. So essentially I treated him as an acute Charcot. And certainly in our unit, we generally tend to prefer using a Bowler Walker, which is from Beagle Orthopedics. And the Bowler Walker looks a bit like this because it keeps the patient more mobile. And if you think about a patient who's BMI 56, lives alone on his own, a TTC will basically render him immobile. He would have ended up in hospital. So this really sort of maintains mobility. And I think there's good evidence that a Bowler Walker from a clinical standpoint is just as effective as offloading as a TCC. Now, normally I don't MR acute Charcot arthropathy, but in this case, I was a little bit worried because CRP was elevated, and I just wanted to understand a little bit about what's going on in the subtalar joint. So this is his MR. And this, you know, and the thing that really stuck out was this kind of massive fluid collection. And now I'm thinking, God, is this sort of infection that I'm dealing with here? And so that was really the primary question that I had. So I actually took him to theatre and I explored immediately. And just this kind of synovial fluid came out, which I sent off to microbiology. And as it happened, there was no growth in microbiology at all. And I never treated him with antibiotics. The subtalar joint dislocation, I was able to reduce, but it required a tib post and FDL tenotomy to do so. And he went back into a bowler walker. So the question that I would put to you guys is, in the case of a acute hindfoot, whether it's ankle or subtalar Charcot arthropathy, is there any merit in any form of stabilization? Because these patients tend to be very unstable. And bearing in mind, at the time, I didn't know whether he was infected or not. So no. Harry, can we have a little discussion about that, about acute stabilization of the, yeah.
Chris, do you want to take that on and fire your thoughts into the arena, please?
Yeah. So the first thing that crossed my mind was that your first ever series of X-rays showed a widened ankle joint space, which immediately rang worry to me, because it's difficult to get a widened joint space under any circumstances. Did you ever get any weight-bearing films? We really nail our diabetic team into weight-bearing films, because I think that would have alerted you much more early to what was going on. You know, you didn't diagnose the subtalar dislocation until you had an MR. But I think
it was only 3 weeks, Mark. It was only 3 weeks.
Yeah, I'm Chris, by the way. But even so,
sorry, Chris.
That's okay. We're almost indistinguishable. I know that. But 3 weeks. 3 weeks is 3 weeks, and I think standing X-rays would have been helpful. I'm not being critical here. I'm just saying it's a sort of as an educational point. I think standing films just tell us so much information.
I completely agree with that. Actually, yeah. It's just in the history. I didn't even know. I didn't see the patient. It was a GP X-ray. It was a G. Yeah. But you're right. If it was in any way a little bit dodgy, then a weight-bearing X-ray I think could be useful. I mean, CT is just we can get CTs on the day, these days. So in that instance, I'd also get a CT as well.
It's the difficulty is the algorithm of trying to tell your diabetic team when you want a CT, when you want an MR, when you want plain films. Yeah, and if you tell them that you always want weight-bearing films, then the alarm bells would have rung earlier. As you say, Harry, 3 weeks is 3 weeks, but you may have had a better opportunity a bit earlier. That's what I'm saying. Mark, okay. You wanted to say something?
Mark?
Yeah. I was thinking, actually, if you've got this great MR image, you can see there's fluid there. And in answer to your question here, I wonder whether you could have got a radiological aspirate of that fluid to give you at least a gram stain and a provisional culture. And then in terms of answering your question, to get acute stability of a Charcot dislocation, I think that is the right thing to do. Certainly if you see an acute dislocation of the midfoot through a Charcot process, then that is what you would do. It's almost your ideal opportunity while things are mobile to get a reduction.
Senthil?
Yeah, no, that's not a stable hindfoot. I mean, you can see it is such a severe dislocation. I know you got it corrected by the tenotomies, but was it stable when you let it go? I have a feeling that would have been quite unstable.
Well, Senthil, I'll tell you now, because it wasn't, because 2 weeks later, he'd completely fallen off.
Okay. Exactly.
Yeah. And so, he'd fallen off here, and literally within, I would say days, if not maybe 2 or 3 weeks or so, partly due to the pressure necrosis from the lateral process of the talus. And also, I suspect, despite the negative microbiology initially, and I did send several samples, I think in hindsight, I think there was infection there.
Why would you think that, Hero? Why would you think that? Well, because there wasn't, I mean, it can't be endogenous infection, but you could get this synovial collection with just a Charcot and a dislocation, couldn't you?
Yeah, I think you can do. Yeah, it's just that the way that it blew out on the wounds over such a short period of time, and this is the appearances literally weeks after I'd taken back to theatre. Maybe less than 3 weeks. You can see talus is exposed, and that wound grew Staph aureus and mixed flora. Okay. So this is what I'm thinking.
So with that degree of instability, Hero, if you put a hindfoot nail up, which might have been what some people would do, you'd have seeded that infection right up the tibia. So there's a real school of thought that says put that foot in jail by putting a frame on it.
Yeah.
Our experience in Sheffield is not great in that regard, I have to say, but I think there would be a very strong argument for doing that really early on.
Yeah, so that was that. There was a discussion, and actually, the discussion about a frame actually comes at this point here. So at this point, it's really pretty desperate, isn't it? So
What'd you do?
Well, okay, right. So he didn't want an amputation. I know what you're saying, Harry. Speed up. So he said, please don't take my leg off. We did have a discussion about frame correction and debridement, and I've heard this once before, but his primary concern about a frame, which I didn't do, was his dog, actually, because he can't keep the dog away from him, and actually he was actually concerned that the frame would actually hurt the dog. Anyway, but he was systemically well in himself. CRP is creeping up. It's clearly infected now, and that was a problem. So, these are the options, really. And this is where I guess my relationship with him kind of played a part, because ordinarily I think a frame would have been probably the ideal option here, but I went along with protection of his dog. So he didn't want that amputation. So I went in there with an acute debridement, put just a pin just to try and stabilize. I definitely didn't want to put a nail up there because it was Staph aureus everywhere. And the pin stayed in for about 3 months or so until basically it fell out. So the good thing is that this basically allowed his wound to completely heal without.
Did you actually debride it then and stuff it with with antibiotic stimulan?
Yeah,
okay.
Yeah. So loads of stimulan went in. You can see he's in a bowler walker, so he stayed in the bowler walker basically to manage the wound until the wound had healed. So the year later, of course, the deformity is the problem. The wound is still healed, but the deformity's there. So we got a 45-degree deformity. Now we're talking about how do I get this patient into a shoe? And the real challenge at this point really was the white cell scan. There's infection everywhere: hindfoot, talus, navicular, and this was the real challenge. What to do now? An unshoreable foot with evidence of deep infection. So I'll just get on with it, and I'll just tell you what happened essentially. So again, he didn't want the same conditions. He didn't want a frame. He didn't want amputation. So took a risk, in discussion with him. So essentially cleared out as much of the infected talus as I could, stuck a hindfoot nail up. A couple of months later, his wound is healed and his foot is reasonably well aligned, except for his little toe. I don't know what happened there. And a few months later, he's walking.
Yeah. Okay.
Okay. Yeah. Okay. So, but at the end of the day, the X-ray is shocking. So, this is what the X-ray looks like. It's a shocking X-ray, but he's walking 2.5 years later. There's no recurrence of infection. But I think in hindsight, I would have made different choices. I think, and I would have had different conversations with this chap. And I think partly my relationship with him did affect the kind of decisions I made, but sometimes you get away with it, and I think so far I've gotten away with it.
So going back to perhaps Chris, would you go back and fuse this again? It's clearly a complete and total non-union, and that nail's going to fail at some stage. He's a big fella.
No, he's going to end up living with intermittent infection, this man. I would say you may be infection-free now, but you and I, and we all know that this will bite him back at some stage. And we've a lot of patients in Sheffield that we've all looked after for a long time, where the relationship, as you rightly said, Hero, is absolutely paramount. And this patient will always thank you for what you've done so far. And you'll need to babysit him through for the rest of his life, which probably you'll do for the rest of your working life. And a time will come when he will, he will get reinfected probably, and you'll ameliorate that with antibiotics and so on and so forth. I wouldn't go back into this until his nail breaks and you have to. And I don't think that will happen. It'll pus out one day, and you'll have to just suck that up and move on. But I think it's about the relationship, exactly like you said. You become part of this guy's extended care group, and I think that's where you'll end up. I wouldn't do anything with him. You're doing great.
Senthil and Mark, would you agree?
I agree. I think at some point you have to go back and again and do it, but I perhaps maybe do a plate fixation rather than another nail or a frame. They seem to provide much better stability. I think the key is stability. I think you can control the infection. Even if there is infection, go ahead and do a good fixation and stabilize it as much as you can. I don't think that nail is actually stabilized it that well. So
I think I'd leave him well alone. He's got a pseudarthrosis and he's not pussing out at the moment. Live for the moment.
Hey guys, we have a question here. What antibiotic did you add to Stimulan? Was it Vanco, Tobra, or both?
Yeah, Vanc and Gent. That's the usual standard combination. Yeah.
And how much did you add to both?
1 gram of Vanc and 240 milligrams of Gent. So that goes in a 20 gram Stimulan. Yeah. Pack.
20 mils.
Yeah, 20 mils. Yeah.
Don't be pedantic, Mr. Blundell.
That's what I got to put up with, Harry.
I know, I can imagine. Okay, well, now we head off to the Sheffield Shamans for their foot and ankle trauma horror show. So, Chris, can you share your screen with us, please? Thank you, Hero. That was excellent. That was a lovely case, and plenty to learn from it.
Okay, so can you see my screen, guys?
Yes, we can.
Yes.
Okay, so Mark and I are going to sort of double act through a number of cases, and we'll just keep going until Harry tells us to shut up. We work in a major trauma centre with a lot of support of plastics and all of the bits that you'd expect from a major trauma centre. So our first case, I'll talk through this one, if that's okay, Mark. So this is a 74-year-old lady driving a car, head-on collision, disappears down into the footwell of her car, and presents with an isolated injury to her right hindfoot, which is open. Plain films through the emergency department are, as you can see, with an open wound over the tip of the fibula here. She gets into CT, which is a sort of very common thing that happens through the MTC. And the CTs, you can see the sagittal and transverse images there. So a pretty complex situation. In the reasons of time, Harry, we won't perhaps discuss everything that we can all see, but I'll talk through them. So we've got a talus fracture, which is comminuted. We can see a fracture line that's running both in a sagittal plane and also a fracture line that's running in the coronal plane. Medial mal's off and a transverse comminuted fracture through the fibula. And if you look there, the sustentaculum is off as well. So we're sitting here looking at an open, complex hindfoot injury, and you can see gas in the soft tissues there, can't you? Which I think is really important. These views show the subtalar joint is not correct, and the cuboid is blown as well. So I suppose we kind of perhaps know what we're going to do, but maybe, Harry, you could ask folk what order of play people would do.
Yeah, okay. Hero, you can kick off the proceedings, you know. This is one of those heart sink cases, so you've got the information, so you can, you know, try and get your gear wheels going and tell us what you think you might consider. Which ones are you going to fix first? What are you going to do with the wound, etc.?
You want me to go back, Hero, to previous images?
Yeah, I think so. Yeah. There's so much going on there. But so in the acute setting, it was an open fracture. So in the acute setting, obviously it's span, scan, and plan. But you know, you've got an acute CT here. But certainly with this type of injury, I'd certainly be looking to span it initially, which basically would allow me to collate my thoughts and plan this a little bit carefully, and also allow some of the soft tissues to settle down. So I'd put the delta frame on the ankle. So in terms of the definitive fixation, I guess, I mean, the joints, you know, the ankle joint is going to become degenerate anyway, but fundamentally we do need alignment and we need stability. So I think looking at that, you've got a convenient medial malleolar osteotomy essentially to approach the talar body fracture. The thing that worries me is the picture in the middle there. It appears to be like a central fragment of the talus, which is kind of fragmented there. So I don't know, maybe that's the posterior element there, but I'd certainly approach the talus through the medial malleolar osteotomy, then stabilize the sustentaculum, and I'll be tempted, as long as there isn't a joint depression element to that, I'll be tempted, because you're on the medial side, just to put a screw from the medial side in the sustentaculum. Fibula, yeah, I think, again, stabilize everything, really. Stabilize the fibula with a little small locking plate. And then the cuboid, that does appear sublux, so we'd have to go for that as well. And I'll probably do the cuboid at the end. So probably need a bit of a spanning plate.
Yeah, so I think it's interesting looking at the lateral sagittal CT there. If you look at that CCJ, it's shut down, isn't it? Because the cuboid is bivalved, and so the lateral column is shortened. Harry, do you mind if I just press on?
Yeah, go for it.
Okay, so essentially the patient was taken to theatre, not by a foot and ankle surgeon, because they were on call, and perhaps a degree of lack of experience meant that the injury was washed out, an X-fix was applied, and they took the opportunity through the medial side to fix the talus. And I guess this is sort of pattern recognition stuff where, you know, talus fracture equals longitudinal screw down talus, doesn't really appreciate the original complexities of the talus fracture. So the X-fix was put on, the talus was inverted commas fixed, and then the other injuries after the weekend. So this is what we pick up after the weekend, is this situation. And I don't think there was an appreciation really of the magnitude of the subtalar joint dislocation, because these films, if we just go back there, the subtalar joint is still not reduced. The talus is still hitched off the back of the posterior facet. So the patient was essentially have the talus revised here and refixed, and you'll see the absence of the longitudinal screw, because quite rightly, the surgeon who did this, which was actually Mark, appreciated that the talus fracture didn't need a longitudinal screw. What it needed was anatomical reconstruction in the sagittal plane, or sagittal plane fracture, which was done. And then exactly like you said, Hero, long medial plate, posterior fragment restored, and the fibula put back out to length. And then the CCJ was bridged out. And it was the CCJ bridging out which allowed the subtalar joint to reduce. And that was really the foot ankle kind of bit in this that I think wouldn't be appreciated perhaps by a general trauma surgeon, is that subtalar joint is going to remain dislocated while ever the CCJ is dislocated, because that's what's swinging the talus in rotation. So I think that's probably the lesson in this case, is think carefully about the order of what you're going to do and consider carefully what the CT scans show.
Did you use a tourniquet?
I did, Harry, yeah.
Okay. Presumably you had to let it down a couple of times, did you? I mean, it must have taken a couple of hours at least.
It didn't take very long because there was a big hole in the lateral side.
Of course.
Yeah. I had to remove all the bits and pieces that had been put in, which took a bit of time. And actually, if you, exactly as Hero said, use that medial malleolus as an osteotomy, you get straight in on the talus. So actually, the first thing I did was to reduce the CCJ, and that then just everything was it fell into place.
Well, that's exactly that's the story. That's the lesson to take home, isn't it?
That's the lesson.
You know, you forget to realize that the stability is afforded by the lateral column, and if it is grossly shortened, no matter what you do, it's always going to remain subluxed.
And I think people other than foot and ankle surgeons would be focusing on that ankle and missing the fact that the subtalar joint is screwed unless you get it right. You obviously haven't worked with Mark in theatre, Harry. It's like the flashing blade. You've got to watch your fingers there. It doesn't take long. Okay, so, you know, what about AVN of the talus? Are we expecting that, guys?
Oh, yeah.
Okay, well, no, I think not.
Not necessarily.
Because remember, the fracture plane is a sagittal fracture plane.
Exactly.
So the vascularity from the medial side and the lateral side is good. So I think not really. And it didn't happen. As you can see, these images are down the track, and we haven't got AVN. And I think in that fracture plane, we're not so concerned. So
did you take the bridging plate out?
We would do ordinarily.
I haven't so far, Harry. She's happy.
Good. Excellent. Let's crack on.
Let's crack on. So, Mark, over to you for case 2.
Okay, so this fellow was up to no good. I don't know why, but he was on the top of a first-story roof whilst drunk. he fell off the roof and in
We've
the
all
flower
been there,
bed.
Mark. We've all been there.
I know,
Be honest.
easily done. 12 hours later, though, he was found in the flower bed and he was transferred to me on call. Otherwise, he's a fit and well chap, and this was an isolated injury. And you can see here that it's a clearly very deformed foot with a burst injury to the lateral hindfoot skin. Thankfully, not particularly contaminated, but of course, there's been this delay before getting to us so that we could do something with him. So, again, Harry, open it to the other chaps. What information do you want about this chap if you've got that man in your ED?
There you are, Senthil. Your turn to go, mate.
Start with an X-ray. That would be useful. See what's happened, and probably a CT scan. I think that would be the two initial investigations I would like.
Yeah, I think that's fair, Senthil. And we'll move on to the next slide. The radiographs were not hugely informative, but clearly the CT is. You can see that there's gas in the ankle joint, and it's subluxated both at the ankle and the subtalar joint with that sort of hitch fragment. And then there's this neck stroke body fracture of the talus. So at the same time, he's got a subluxated subtalar joint, and it's much more comminuted on the medial side of the talus. So just to summarize, we've got an open burst wound of the lateral hindfoot, gas in the ankle, subluxated ankle and subtalar joint, a neck stroke body fracture with subluxation, and there's comminution on the medial body of the talus.
So was there a chunk of talus that actually came through the lateral wound then?
No, it was all there. Everything was there. The whole jigsaw was there, but it needed to be put back together. So I guess how do we handle this, chaps?
What can you actually feel through the open wound? Was it the talus? Was it the lateral malleolus? Do you know?
Well, I think it was mainly lateral malleolus that you could feel, Senthil. That burst wound was not particularly informative, to be truthful.
Harry, you're on call at the moment. You're probably going to get one of these tonight. Why don't you take a moment and tell us what you might do?
Okay, well, I mean, what is obvious is it's a highly comminuted talar fracture. There's an open wound, so clearly wound toileting, etc. And then go back to the span, scan, and plan phenomenon if there are other injuries to cope with. You said it was an isolated injury, so I think it's well worthwhile trying to piece the jigsaw together. Not far easier to say, but clearly there is significant subluxation of both the ankle and the subtalar joint, which needs to be reduced. I would probably go through the lateral open wound, extend it. I may have to use additional incisions, possibly a medial incision if I can't gain access. But I think a lateral wound will be my first search point to try and piece together the fragments. I'm still trying to work out what's happening with the syndesmosis, for example. Was the syndesmosis intact?
I don't think that's a problem, Harry. I think we're looking at everything is below
talus.
that. Yeah.
Everything is talus, and the os calcis presumably is intact too.
That's absolutely fine on this fellow. Actually.
Okay. Again,
So,
the question is, have we got all of the fragments ready and available to put back together again? Headless screws. I might possibly consider building a frame around it, or use a femoral distractor to try and open the area up to try and gain good access and try and put the fragments back in.
Okay, I mean, I think that's very reasonable. I was worried about the lateral wound. So the next slide asks the question which approach to do, and I think you're quite right. It's one of those slight conundrums as to what is the best way of accessing this talus. So actually, what I did do is the following slide, which was a medial malleolar osteotomy. I did wound toilet, so everything as you suggested on the lateral side. But I felt that there was that jammed in fragment underneath the medial malleolus. And I was thinking, where on earth does that come from? I'm going to need to see it, but I knew that the body was involved. So I did this medial malleolar osteotomy. And next slide shows literally a selection of headless screws, but also polyglycolic acid pins just to literally fix things in situ. So Chris is doing my slides, and that's brilliant. He's showing exactly what I want to see. And then
They looked like there was a little plate there on that earlier, the one before this. What was that?
That's just fluid.
Yeah, there's no plate there, Harry. No.
Sorry.
We don't own any plates in Sheffield.
Harry,
yeah, I meant that. Yes, yeah.
No, that's just water. That's sweat. That's sweat.
The sweat.
So a bit like I've got into the habit now when you have these nasty taluses where you've got poor soft tissue envelope. I do put them in an external fixator as their plaster of Paris afterwards. It just allows you great vision of their soft tissues. And so you can see that I've done that here, and the fixation, as you can see on the right-hand side. So it kept it to a minimum.
Just curious, looking at that X-ray, is there an extension deformity at the fixation mark? I'm not being critical, I'm just observational. Is there, that one there? It looks like there's a kind of flexion at the talonavicular joint level. And is there a dorsal subluxation, do you think? Or is it just me?
No, I don't think it's just you, Harry. I think that it's a possibility, but I think it wasn't gross, thankfully.
I was going to suggest an anterior approach, or anterior extensile approach, I would call it. That, in my experience, gives you a very good view of the talar neck and the body, and in combination with your lateral incision, I think that would have been given a much better exposure.
You've just got to be so careful, Cynthia, with what you do with the blood supply, because it's so tempting when you do that to work your way laterally and medially, and the next thing you know, you've devitalized.
But the predominant blood supply is through the lateral sinus tarsi, and I think if this is already, he had a big open wound, then it's probably gone, and then you're relying on the medial blood supply. I think there's very little blood supply actually enters through the neck in the front. In fact, I think so. I think I've done a few of these cases through the anterior approach. I think we are very used to that as ankle replacement surgeons and so on, and it's much better view of the whole of the talus. And in fact, I wrote it up as a paper some time ago. So that would have reduced your talus in the body, because if I am correct, the next slide showed that there's a bit of a deformity developing there.
Cynthia, do you reckon you could get that sagittal split back through an anterior approach, though? You've got to try and fix that medial side to the lateral side. It's going to be really hard to do from the front.
Well, I think that's why I think if you have a lateral approach as well, a lateral incision where you could see that, you should be able to fix that.
But the problem, Senthil, was the chunk that was lying below jammed in below the medial side. Yeah. And I personally think that would have been really difficult to actually fish out through an anterior incision unless you dissected all the way medially, wouldn't you?
Well, the anterior end of that fragment, you could actually see it coming into the neck. So you should be able to see it from the front. See, one of those sections, you can actually see it.
Okay, all right.
Fair enough. So, Mark, I'd like to commend you on your osteotomy. It's actually a beautiful example. You need to use that for your teaching slides. It's properly, the exit point is properly lateral, because that's the problem with doing a medial malleolar osteotomy, isn't it? It's just
correct.
It comes out the medial gutter, essentially. You can't see what the hell you're doing with a talar body. That's proper lateral. And that's really sort of nicely a vertical osteotomy, which is great. The only thing which I would ask you is, I often find that when I make the osteotomy, the line of the osteotomy is more vertical, and therefore the fixation I find is more reliable if I actually put my screws in horizontally across. So in other words, parallel to the joint line. So an anti-glide at the apex of the osteotomy, and then two subarticular screws. But you probably pre-drilled it, didn't you?
No, I agree with you, and that's what I would ordinarily do. To be honest, I didn't need to get too far lateral in this instance, and if I do, then I would do exactly as you suggest, because it's more of a platformplasty rather than a medial malleolar osteotomy. I think that's absolutely right.
I think we should stop calling it medial malleolar. We should be calling it medial plafond osteotomy.
Yes.
Yeah. Correct.
Good. Yeah.
So
have we got two more cases, Mark?
Yeah, we've got two more cases.
We've got 9 minutes to go, so might as well wait.
Why don't we skip through to the next one then?
Well, let's not. Well, because this is important to finish off, and then we'll skip through the last one quickly. Go on, let's finish this story.
So this chap, unfortunately, then ended up with a problem with his medial wound, and these are X-rays literally 8-10 weeks down the line. And any thoughts from you chaps?
Hero?
Well, he's clearly having a problem, isn't he? Because he's not weight bearing. I mean, there's disuse osteopenia. There's, the thing that, well, I mean, it looks like infection because it's periosteal reaction on the medial side. And there's loosening of the screws. So this is infection until proven otherwise.
I think you're right, Hero. So we'll move on 2 slides. And basically, the next step that I did was to aspirate through an open wound some fluid, and actually it came back as negative, and he hadn't been on antibiotics. So I was slightly disappointed in a way not to have something to hang my hat on. But things sort of did grumble on and then settle, and the next set of images I think show that it's literally just progressing. Whatever's going on, it must be infection. You can see I've removed one of the screws when I did my biopsy, and arthrosis and probably deformity because of the slight malreduction of the talar head component. So we then CT'd him, and you get this horrendous moth-eaten look that you can see here. It's really starting to look very unhappy, and I think actually I handed him over to Chris at this stage, and the next set of images shows exactly what we did. And thankfully, he settled down. But it was a long old haul, this one.
Well, that was also a pretty brave decision. If you did think that there was potentially infection there and you were driving a nail up, that was a brave decision, but clearly it's worked really well for you guys.
It was pretty radically debrided, Harry, and the nail was bathed in Stimulan at the same time. So, anyway, there we go.
Excellent. Okay.
So, sorry. Let me go to case 3 then. So, standard Sheffield unit, 24-year-old guy without really giving us a history. We don't really know what happened to this guy, if I'm honest with you, but there was some story of the police and a dirt bike. This guy presents with these x-rays and an open injury. And you can see a kind of theme to what we deal with here. So span, scan, and plan is the mantra. The honest truth is, though, with the MTC is that these patients get a CT as they go through the unit. So quite often it's actually scan, span, scan, plan. And then Mark and I quite often do scans down the track. So they end up with scan, span, scan, plan, scan, which is a lot of scans, but it gives us the information we need. So debrided, and this is a real good case of shared care. So debrided and spanned at the outset, let those soft tissues go. So the first definitive scan of his hindfoot is with an X-fix on. So I think we can see, I'll just bide it really. So talar navicular doesn't look right, does it? Cuboid blown as is often the way. Anterior plafond doesn't look great either. So we've got, again, a sort of a hindfoot and ankle problem going on here. So we staged this and decided to start with his Chopart complex because he's got this lateral wound. So that wound needs to be clean before we can extend to really fixing his cuboid, which we, again, like the first case, we think is really important to realign the hindfoot. So he starts with his ankle. So you can see again here, a sort of minimally invasive stabilisation of his lateral malleolus with just one 6-5 screw, and then a nice big plate on the medial side to get that ankle right. And if you look at his Chopart's joint now, it's reduced but not stable. So we then go on to bridge here because his navicular is blown, and so we tend to bridge these through the first cuneiform into the talus with a bridging plate and fix his cuboid with a sort of snazzy little cuboid plate. We know that those plates, when you bridge these navicular fractures, they either break or we need to remove them. Mark and I just wanted to just perhaps throw out, for those who are still on here and interested, that we've classified and published cuboid fractures in the JBJS in 2016, and there's a sort of comprehensive classification of these injuries which overlaps with this paper, which was the navicular classification paper. So you can see at the bottom there that type 5s are both the cuboid and the navicular, which is what this guy had. So there's the soft tissues, and we let those, that was his original blowout that you can see on the sole of his foot. So hence the sort of dirt bike sort of deceleration into the ground. created that wound. And we end up with a situation like this. So we've got the ankle fractures fixed, the Chopart's joints bridged and stable. But if you look here, if I can make my mouse show, you can see that plate's failing.
Yep.
Here, the screws are breaking. So important to counsel your patients about that. I don't know whether you guys would take that hardware out. What would you do, or would you not do it?
I think the Navicular plates are very poorly tolerated, so you have to take them out. In my experience, earlier the better. I don't think it is lost any more than 2 months, 3 months, and then it starts to fail. So then it becomes painful as well for the patient. So,
I have to be honest and say I don't take them out. I just let them break because it's a further insult to the soft tissue. So I don't bother with that. I just let them break.
It depends on the patient,
We've got 2 minutes, guys. Okay.
So I think, as Hero's about to say, it does depend on the patient. So some patients are very anxious and you need to take them out. Some patients are relatively low demand and you can leave them. But the screws in the plate can cause problems to the wound if you leave them too, as well as if you take them out. It's a tricky situation, but I thought I'd just throw that up there before our last case, which it sounds to me like we haven't really got time for.
I'm afraid we're likely to run out of. But
okay,
you can run through it if you want. Yeah.
No, all I'm going to show you is perhaps these set of images here, because this was the other side. This was the perhaps arguably less injured side in this patient. Perhaps Mark can in 1 minute just talk about the decision making here.
Yeah, insane man who stayed insane for months after falling and closed injury. The frame guys really didn't want to do anything with this chap because he wouldn't tolerate a frame. Internal fixation was impossible. So we came to the conclusion about rebuilding his pilon with a custom prosthesis, which you can see here with a model to work out your section margins, reaming up to allow for the stem of the implant, packing the implant, and then fixing the implant, which is the next slide, and then the post-operative images at 4 years. And this chap's reasonably happy, given his mental state. He's got 2 legs. His other leg is not great either, but that's my triple fusion to rescue his open hindfoot. Disastrous injuries these, but those custom-made prostheses might be a way out of some of our problems that we've talked about tonight.
Did you use the fibula as the bone graft, Mark?
I did, yes. I did. Yeah. I put it through a spinal
We do a
bone.
lot of those custom implants at our institution between myself and one of my partners, and they allow for a tremendous amount of limb salvage. So, hey, Karthik, that was a great session. Some amazing cases you guys showed, and some wins that you guys got. But thanks all of you for hanging out with us. And Karthik, thanks again as always.
Brilliant.
We'll be back in a few minutes.
Thank you very much, guys. Well done indeed. Brilliant stuff. Thank you.
Thank you.
Bye bye.
Thanks, Mark, Hero, and Chris.